Good afternoon, ladies and gentlemen. First of all, a huge thank you to Sanjay Agrawal for having me here. I've found out in the last few months that the best job in the world to be a deputy of something because you have to do nothing at all. Sanjay, thank you very much for keeping it that way. So it is an honor for me to follow Professor Small and Professor Chevalier on this topic because they have reduced the size of my talk from 20 minutes to 10 minutes already by covering everything that I was going to say. I'm one of the surgeons at Sunderland, for those of you who don't know me. So without any further ado, this is the if so mandatory disclosure slide so that you know that what I do. So most of my practice is primary surgery, and increasingly I'm doing more one anastomosis gastric bypass and Roux-en-Y. Some of my colleagues will have a different ratio than I do. I have received small amounts of money from various corporates and NHS organizations, which you need to know about, but I don't think it would conflict what I'm going to say too much. In 2012, when Sunderland adopted this operation, it was controversial. And to say that, we were criticized big time. And I was also banned from a so-called club for saying it is a controversial operation, but that's a different story altogether. 2019, my friend Mr. Palmer and I did another review on the same topic, and we now think it is not controversial anymore. And I would hope with this I would be inducted back into the club. Love to say. It is a recognized procedure, which is now being recognized by the IFSO. We were part of the IFSO position statement that came out last year. Many of you may have seen it. And Sunderland Group was instrumental in pushing for the first consensus statement that has names of so many eminent surgeons, and many of them are sitting in the room here today as well. So it is here, and it is recognized by the community. And the numbers are increasing rapidly. This slide by Professor Angrisani's the group and the paper that he published on behalf of IFSO has been shown to you earlier today as well. I would just like to point out one or two things here, if I may. If you see this green bar is obviously sleeve gastrectomy rising and rising and rising. That is the Roux-en-Y gastric bypass, and this blue bar here is the one anastomosis gastric bypass. Those black arrows are of mind making. They're not from Professor Angrisani's paper. That is my extrapolation of what may happen if the same trends continue. And I think in a year or two's time, OAGB may well surpass Roux-en-Y gastric bypass in terms of the total percentage of primary operations across the world. Having said that, we in Sunderland have already done that. Last year, for the first time in the history of our bariatric unit, we performed more one anastomosis gastric bypasses than Roux-en-Y gastric bypasses. We are running behind, and I know that many of you have seen these slides at times and again. If you want the slides, I can email them to you, or you can take my word for it for now. So Lee's RCT, which Professor Chevalier quoted as well, it showed superior weight loss with Roux-en-Y gastric bypass. The results were not statistically significant. However, what was statistically significant was the complication rate, but Lee's group, it was said at the time, was in their learning curve with the Roux-en-Y gastric bypass, so those results were not credited very much, I don't think, by the bariatric community. More recently, Sita Ramaya et al. From Kolkata, where I was born, they have done RCT comparing one anastomosis gastric bypass with sleeve gastrectomy, and they have found that percentage excess weight loss for OAGB was statistically superior to sleeve gastrectomy, and also in terms of diabetes effectiveness, OAGB had better outcomes. More recently, and you heard this from Professor Chevalier as well, the Omega trial has shown that with OAGB 200, and we must mark the BP limb there, OAGB 200, and we must make a note of that, the outcomes of OAGB were not inferior to Roux-en-Y gastric bypass in an RCT setting. And as you may well be aware, this RCT showed no difference in complication rates according to Kelvin-Dindo classification, which the authors chose not to highlight in their conclusion, but they did have a higher malnutrition-related complications, which they chose to highlight very significantly, and that got all the publicity in the social media and elsewhere. I have written a detailed response in reply to this article, which has been published. If you want, I can share that with you later. But OAGB 200 has problems, and Professor Chevalier has pointed that out to you. We've seen several deaths. I've only just taken out one paper here, but there have been deaths, many deaths there. I think more than a dozen deaths have been reported with limb lengths of 200 centimeters or more. And we found in our survey, which Professor Small quoted, that we found that people who were doing 150 or less were not reporting those complications, whereas others were. And on the back of that, we were also looking at the Roux-en-Y limb length data, and our conclusion was that doing anything more than 150 centimeter is probably not a good idea and possibly stupid. We have known in the past that OAGB 200 has problems. Even Rutledge, 15 years ago, reported 1.1% malnutrition requiring reoperation rate with his series of 2,410 patients. That was in 2005. Rutledge data, which shows 1.1% malnutrition, you know that many American colleagues say is underreporting because many of his patients were operated by colleagues elsewhere in the United States. So I'm not saying that's true or not true. I'm saying that possibly the malnutrition rate was higher than 1.1%. He also, in his papers, he has said limb lengths of 180 centimeters in the figure and 200 centimeters in the text. So one does not know which limb length he used. And when I've asked him directly, I haven't got a clear answer. So I'll have to leave that to your interpretation. And we also know from Lee's data, which is the second table there, that there was approximately 1.1% malnutrition rate in his practice as well. And he was using a tailored limb length depending on the BMI of the patient. That led to our conclusion, which Professor Chevalier pointed out, that doing anything more than 150 is possibly not a good idea with one anastomosis gastric bypass. It was confirmed by the study from Ahuja et al., once again, which was shown to you earlier, that if you do 180 centimeters or 250 centimeters, you increase the malnutrition rates, you increase the hyperalbuminemia rates, you increase the liver failure rates, and patients die sometimes. So not a good idea again. We have submitted our results. We have compared our OAGB 200, which was our historical cohort, to OAGB 100, which is our current cohort. This is the weight loss at 18 months. We chose 18 months because we thought weight would have stabilized by then, and we have 85% follow-up on this. This study has been submitted. I've been asked to revise it, so I will be submitting it again. And this is the unpublished data that we have got here. As you can see from this table, the BMI as well as the weight was higher in OAGB 200. So I think in switching over, we were a bit behind in terms of super obese and not super obese. So we have done separate subset analysis of super obese people and people who are BMI less than 50. And once again, there's no weight loss difference. Even numerically, you won't see any, and statistically, certainly not. So my personal bias is that OAGB 150 is probably as good as OAGB 200 in terms of the weight loss outcomes, and definitely much better in terms of malnutrition outcomes. Is it a good metabolic procedure? I think yes, but I will tell that I'll share some more information on that topic tomorrow with you. But will it not cause cancers? Because it hasn't been touched by Professor Small and Chevalier, so I'll talk about this a little bit in depth. There are now 2 reported cases of esophagogastric junctional cancers following one anastomosis gastric bypass. One of them I'm aware is from Professor Agrawal's group, but I know the operation was not performed by your team, Sandeep, and the patient who came from a different center didn't even have a preoperative OGD. But both of these patients in the case reports are men, and both had a BMI of more than 50 before the surgery, and both had other risk factors. and as I said, no satisfactory preoperative endoscopy, so we don't know if they had Barrett's or not. They probably didn't have cancer at the time because they wouldn't live for too long, for 2 years after that. So what we now know is that there are 2 published cancers out of approximately 15,000 published cases, because the systematic review that Mr. Parmar published with me, and that had approximately 12,500 patients itself, and there have been some more series published since then. I agree that there may be unpublished cases, but then the denominator also would be larger in my estimation. When we did a survey 2 years ago, we found that approximately 70,000 cases were recorded in that survey itself. So I'd like to think the denominator is possibly more than 100,000. So you take your pick, but my personal bias is that this operation will not eradicate esophagogastric cancers. And now, obviously, with all the controversy around it, any cancer that is happening in these patients would be blown out of proportion. What we need to see is that, is the cancer rate higher than expected in this patient, in this high-risk patient population? And that data, I don't think I have seen it yet. I don't think you will see for some time or ever in your life. And I say that because tens of thousands of Mason's loop bypasses were performed in the United States alone in the 1960s. And in those patients, We heard today that esophagogastric cancers are relatively common in the Caucasian population. Both of these cancers account for the first amongst the top 11, 12 cancers in the Western population. And in those patients, we have seen so far one reported cancer in the pouch following a loop gastric bypass. And hence, I say that I don't think we will see an epidemic of cancers in these patients. Again, you can show study after study, and this is one study showing that gastric surgery and Billroth 2 is mentioned in the text somewhere, is not a risk factor for esophageal cancer. Again, Billroth 2 is not a risk factor for gastric cancer either. In this study, authors did not find any correlation between the type of reconstruction and the incidence of early gastric cancer after surgery. And we have looked at that in some depth and published that as well. The 2 papers from Sunderland on that topic. And in the first consensus statement also that we were involved with, most of the experts didn't hold the view that it would increase the cancer risk. So my personal bias, ladies and gentlemen, is that the cancer risks probably would not happen. We've talked about ulcers already, so I'll leave that. Internal hernia, again, Professor Small has mentioned, so I'll leave that. Reflux does happen. And there's now data to show that bile reflux is common after this operation in the gastric tube, but possibly not in the esophagus. And there's another study comparing it with sleeve, which shows that it causes less reflux than sleeve, but it's not a competition in life, is it? Most of these patients can be managed conservatively. Approximately, as Professor Chevalier has shown, some patients will need conversion to Roux-en-Y gastric bypasses. We feel there's a learning curve effect to it. So in our first 100, 200, we think it's approximately 5%, and that is gradually coming down to somewhere between 1 to 2%. So when I consent patients, I consent them for approximately 3 to 5% conversion rate in the long term for symptomatic acid or volume reflux. That again has to be balanced against the higher risks of other reoperations in other operations. For example, with sleeve, I tell them that you'll have a higher risk of reoperation for acid reflux, whereas for Roux-en-Y, you have a higher risk of reoperation for internal hernia or chronic abdominal pain. So they pick and choose what they want really. So with that, I think I've saved some time for you, Mr. Parmar there.
Yes.
I'd like to conclude that one anastomosis gastric bypass is now a recognized mainstream bariatric procedure, and I suggest that we do more studies to evaluate the limb length of 150 centimeter or even shorter with this operation. Thank you very much.